Our transfer is open, but it's not receiving or sending because the federal system is not. So that's what's going on in terms of concurrently how the federal exchange interacts with us. So for many of you, you just lost 6 minutes of your life, but for some of you, I think this is going to be what, more than anything else we've done, changes the actual experience of individuals in seeking services. And you were probably thinking this is just for Medicaid. It is not. It is for any income-tested program. WIC, TANF, nutrition assistance, any income-tested program will now run through this one system, which then think about the decision support capability to know, instead of program by program by program, we will now know at an individual level what services individual Ohioans are accessing and be able to coordinate those. Transformation. Okay, so that's streamlined. One example of streamlined. What I really came to talk about, though, is paying for value. This is what we've been working on with the most intensity over the past couple months. Several people in the room have participated in this process. The governor has an advisory committee of health systems, health plans, patient advocates. It's a small group, maybe about 30 people, but we use that group then to tap into a broad expertise around the state of folks who understand how to enhance primary care and how to pay based on episodes or bundles to get better value out of care. And those are the elements that I want to talk about for a couple minutes. So the urgency for this conversation is embedded in this. All my pictures are complicated, I'm realizing, as I look at this. Healthcare is complicated. The urgency for what we're doing on payment innovation is embedded in this. The red bar is Ohio. So you can see that Ohioans spend more per person on health care than residents in all but 17 states. So the height of that bar is average health spending per person in the state. So we pay on the high end compared to other states. Our position left to right is health outcomes. 36 states have a healthier workforce than Ohio. So we pay on the high side and we get results on the low side. That is a value statement. The quality of the product for the price you pay. So we could try to bring price down so it is more in line with a state that ranks 36 in outcomes. But instead, I think what we should do is hold price steady, at least, or bring it down a little if we can. But what we really want to do is move from the right to the left. What we really want to do is improve outcomes. So, the engine behind this is that today we really do get what we pay for. We pay for individual units of service. So we get a lot of individual units of service, whether or not they're contributing to improving care. It's not right or wrong. It is wrong, but it's not fault. It's how the system has just emerged over time. So how do you deconstruct that to take the financial incentive away from just constantly generating more to attach the financial incentive to generating better outcomes at a reasonable cost? That's the key question. I think everybody for a while has believed that part of the answer to this is shifting from a fee-for-service environment to a population-based environment. Everybody is looking for the accountable care organization, where an entity takes responsibility for all aspects of health for an individual, and then you pay them some set amount, and they're responsible for arranging all aspects of care. Because it's a set amount, their incentive is to keep them well at a low cost. We are getting close in some areas to what I think functions like an accountable care organization. But it's still proprietary. It's still ACO versus ACO in a geographic region, or it's health plans saying, we are the ACO of the future, or it's health systems saying, we are the ACO of the future, when really it's probably a hybrid of those two organizations. So this is an unresolved issue. The federal government encouraged states to get people together to innovate on new ways of paying for enhanced primary care, episode payments, or accountable care organizations. Because of what I just described, we thought the state refereeing the ACO thing isn't an appropriate role, even though we do agree that's eventually likely where we're headed. But enhanced primary care and greater efficiency around particular episodes are the building blocks you need to eventually work toward being an accountable care organization. So that seemed like a good place for us to focus. So we focused on enhanced primary care and episode-based payments. If you would make this proportional today, the fee-for-service box would take up most of the space. There would be a little population base, some enhanced payments for patient-centered medical homes, that kind of thing. And there would be practically nothing in the episode category. In the future, hopefully, it's all population-based, and maybe some episode or fee-for-service embedded under that. But to get from where we are to where we need to be, we believe this double strategy of enhanced primary care and episode-based payments is the way to go. I want to say a little more about where we are. After a lot of work, we came to this goal statement, and really what we're doing next is in the yellow. We have two tracks of payment innovation around patient-centered medical homes and episode-based payments. Here's the key. We reached out to the 5 largest insurers in Ohio, and they committed to us that if Medicaid goes in this direction, they will alter their payments to follow. That is a really big deal. So think at the practice level, instead of you're a patient-centered medical home, and Aetna pays you one way, and Anthem pays you another way, and Medicaid, so I don't know how to change my practice to accommodate each. But imagine if all your payers said, okay, look, if you meet these basic definitions of patient-centered medical home, we will all give you an enhanced payment. Suddenly, you have a real financial incentive to take that step. So Anthem, Aetna, Medical Mutual, United, and CareSource, by enrollment, are the 5 largest plans in Ohio. The CEOs of those organizations sat down with the governor 3 weeks ago and committed to him that they'll do what's in the yellow. So in 2014, focus on Southwest Ohio's Comprehensive Primary Care Initiative as the learning environment for building out patient-centered medical homes statewide. And on episode, we are leading design teams to build out 5 episodes: asthma acute exacerbation, perinatal, COPD exacerbation, PCI, and joint replacement. And the payers have agreed then to change how they pay using our methodology on at least 3 of those episodes. So this, I think, has real potential to start changing that dynamic of paying for units versus paying for value. Here's a little bit of information about CPCI, the Comprehensive Primary Care Initiative in Southwest Ohio. There are other enhanced primary care initiatives around Ohio. We are not only looking at CPCI. The key is it has federal endorsement and Medicare participation. So it made sense to start there because it already has the federal government's attention. And then the things that seem to work, we would propose taking to the rest of the state. I'm going to pass over that and go to some detail on episodes. I do want to say a little bit about the episode model. Mostly what folks are wanting to do is get to a point where they say, okay, joint replacement, here's money, you provide that service. Kind of a prospective thing where there's an amount of money for the service. The problem is our systems really can't handle that yet. What we're proposing is a slightly different variation on that, using our existing infrastructure where a patient seeks care and selects the provider they want, providers submit claims, and payers reimburse for all of the services as they do today. 1, 2, and 3, exactly like it is today. But then, with the information the payer now holds about those claims, review claims from the performance period to identify a principal accountable provider, calculate the average cost per episode, and compare those costs across providers. And then providers can make some choices. Share saving, or providers may share in the savings if their cost is low, pay some of the excess if the cost is high, or see no change if they're kind of in a middle range. This kind of comes alive in this picture. What you're looking at here are principal accountable providers around a particular episode that is already risk adjusted, outlier cases are taken out, as well as can be done. These are similar cases. The only thing that's different is price. So you can see in the red, some providers have a very high price. In the green and blue, some providers have a very low price. Payers then can set payment levels where they choose. We don't want to tell them how to do that, but using this data, and this is all payer data, it is not Anthem's or Medicaid's, you take that information from all of the payers and combine